first part of our recorded lecture for hepatobiliary, we've ended with ascites. So just for a recap, this condition is the accumulation of the fluid within the peritoneal cavity. It is also seen as a result of portal hypertension and the leakage of excessive fluids from the portal capillaries. Aside from cirrhosis, it may also result from chronic hepatitis, congestive heart failure, renal failure, and certain cancers. Abdominal sonography is commonly used in detection or confirmation of ascites. Diagnostic and therapeutic parasynthesis may be conducted with sonographic guidance to locate a site that will allow fluid to be removed and to avoid damage of the floating bowel loops. A diagnostic parasynthesis involves removal of 50 to 100 ml of peritoneal fluid for analysis. Patients with ascites generally complain of nonspecific abdominal pain and dyspnea. Medical treatment of ascites includes bed rest, dietary restrictions of sodium, use of diuretics to avoid excess fluid accumulation, and treatment of underlying cause. So here's a procedure of how to perform parasynthesis. So first, after the patient's bladder has been emptied, position the patient and clean the area with betadine or chlorhexidine solution in a circular fashion from the center out. Then apply a sterile drape. Explain the procedure to the patient and obtain a signed informed consent if possible. Explain the risks, benefits, and alternatives. Use a 5 ml syringe and a 25 gauge needle to create a skin wheel of lidocaine at the entry site. Use the scalpel to make a small nick in the skin to allow the catheter to pass easily through the skin. Slowly insert the catheter perpendicular to the skin in small 5 mm increments to minimize the risk of vascular or bowel injury. Apply constant negative pressure when advancing the needle. Loss of resistance will be felt as needle enters the peritoneal cavity and ascitic fluid will fill the syringe. Continue advancing the catheter at an additional 2 to 5 mm to avoid misplacement of the catheter when advancing it into the peritoneal cavity. At this point, firmly anchor the needle and syringe to prevent further advancement of the needle into the peritoneum. Next, use the opposite hand to hold the catheter and stopcock, advancing the catheter over the needle into the peritoneal cavity. Any resistance when advancing the catheter may indicate that the catheter has been misplaced into the subcutaneous tissue. If this occurs, withdraw the needle and catheter together as a unit in order to prevent the bevel from cutting the catheter. While holding the stopcock, withdraw the needle. The self-sealing valve will prevent any fluid leak. The three-way valve and stopcock control the flow of fluid and prevent fluid leak when no syringe or tubing is attached. Attach a 60 ml syringe to the stopcock and aspirate fluid, then transfer the ascitic fluid to the specimen vials. Connect to one end of the collection tubing to the stopcock and the other end to the vacuum bottle. Some practitioners recommend administering 25 ml of albumin for every 2 liters of ascitic fluid removed. For example, a patient had a 4-liter parasynthesis should receive 50 ml of intravenous albumin over 2 hours. The rationale for giving albumin is to avoid intravascular fluid shift and renal failure after a large volume parasynthesis. It is important for the radiographer to be aware of the clinical diagnosis of ascites because the fluid accumulation makes it difficult to adequately penetrate the abdomen. An increase in exposure factors is necessary for this condition to obtain a diagnostic quality radiograph. Large amounts of ascitic fluids gives the abdomen a dense, gray, ground glass radiographic appearance. When the patient is in supine position, the fluid accumulates in the pelvis and ascends to either side of the bladder, and it gives a dog-eared appearance. Next inflammatory is hepatitis. It is relatively common liver condition, and this inflammation interferes with the liver's ability to excrete bilirubin. It is the orange or yellowish pigment in bile. Clinical evidence of the disease includes nausea, vomiting, discomfort, and tenderness over the liver area, and laboratory results indicate a disturbance in liver function. Additional signs and symptoms include fatigue, anorexia, photophobia, and general malaise. So jaundice may also develop within 1 or 2 weeks because of the disturbance of bilirubin excretion. If the liver inflammation lasts for 6 months or more, the condition is classified as chronic. The diagnosis of viral hepatitis is usually made through laboratory testing because the disease is carried in the bloodstream during the acute phase. Evidence of hepatitis may be seen on radiographs of the abdomen that demonstrate hepatomegaly, although this is a non-specific finding. Cellular necrosis may be confirmed through nuclear medicine scanning of the liver, CT, or biopsy. Sonography is also useful in distinguishing the characteristics of liver. Percutaneous liver biopsy is a gold standard for determining the type of disease that may be present in the liver. This is a recommended diagnostic step when the liver appears irregular on sonography, CT, or MRI. At least 6 types of viral agents that cause acute inflammation of the liver have been identified. First is the Hepatitis A virus. It is a single-stranded RNA picornavirus. It is excreted in the GI tract in fecal matter and is spread by contact with an infected individual, normally through ingestion of the contaminated water. It is the most common form of hepatitis and is highly contagious. The incubation period of the disease is relatively short. It is 15 to 50 days, and its course is usually mild. It does not lead to chronic hepatitis or cirrhosis of the liver. Next is the Hepatitis B virus. It is transmitted parenterally through infected serum or blood products. Its incubation period is much longer, which is 50 to 160 days, and it is more severe than Hepatitis A virus. The etiologic makeup of HBV or the Hepatitis B virus is very complex, consisting of a viral core of DNA which replicates within the cells of liver. It may result in an asymptomatic carrier stage, acute hepatitis, chronic hepatitis, cirrhosis, and hepatocellular carcinoma. Vaccination has dramatically reduced the incidence of infection, and the vaccines are safe with very few side effects. Another type of hepavirus is HCV or Hepatitis C virus. It is caused by a parenterally transmitted RNA virus, and this accounts for 80% of the cases of hepatitis that develop after blood transfusion. HCV may cause either acute or chronic hepatitis, with 10 or 20% of affected patients eventually developing cirrhosis of the liver. Hepatitis D virus is caused by an RNA virus and occurs only concurrently with acute or chronic HBV. It cannot occur alone. Hepatitis E virus is also an RNA agent, and it is most commonly responsible for outbreaks of waterborne epidemic and acute hepatitis in developing countries. Although the infection may be severe, it does not progress to a chronic state. The last type of hepavirus is HGV or the hepatitis G virus, which has been recently isolated. It may also be transmitted via blood products and may cause chronic hepatitis. Next inflammatory condition for hepatobiliary is cholelithiasis, or commonly known as gallstones. Women are more likely than men to have them. Their occurrence is also more common in people with diabetes, those who are obese, older adults, and individuals who eat primarily a diet high in saturated fat, sugar, and sodium, and low in fiber and nutrient density. Heredity plays a role in the development of gallstones, and it can also be located anywhere in the biliary tree aside from gallbladder. Symptoms associated with this condition may be vague, including bloating, nausea, and pain in the right upper quadrant. About 80% of all stones are composed of a mixture of cholesterol, bilirubin, and calcium salts. The remaining 20% are composed of pure cholesterol or a calcium bilirubin mixture. Most stones are radiolucent because only approximately 10% of all stones contain enough calcium to be radiopaque. Those radiopaque may be difficult to distinguish from renal stones, but an oblique projection helps to separate the two structures, which is the kidney and the gallbladder, from each other. The gallbladder is demonstrated anteriorly to the kidney. The presence of cholelithiasis is readily demonstrated by sonography. The best image is obtained when the gallbladder is distended and filled with bile. So an 8-hour fasting is required for the patient before the sonographic examination. The three major sonographic criteria for gallstone include the echogenic focus, acoustic shadowing below the stone, and gravitational dependence. It is highly recommended that patients who do not have fever, have normal WBC counts, and have gallstones as demonstrated by sonograms undergo cholecystography, abdomen CT, and MRI of the abdomen to ensure that other forms of biliary disease are not present. So surgical removal of the gallbladder is usually the treatment of choice. Next is the cholecystitis. It is an acute inflammation of the gallbladder, and it is common in individuals with chronically symptomatic cholelithiasis. It is characterized clinically by a sudden onset of pain, fever, nausea, and vomiting. Its diagnosis is clinically suspected and supported through a sonographic examination or radionuclide cholecystography. Non-visualization of the gallbladder is a good indicator of acute cholecystitis. Repeated attacks of acute cholecystitis cause damage to the gallbladder, thickening of the walls, and decreased function. Occasionally, a stone may erode through the wall of the gallbladder in cases of chronic cholecystitis and create a fistula to the bowel. If the gallstone becomes impacted in the small bowel and causes an obstruction, the condition is referred to as the gallstone ileus. This is characterized by air in the biliary ductal system, clearly visible on a conventional abdominal radiograph. Surgical removal of the stone is necessary to relieve the obstruction. Treatment of chronic cholecystitis is also included laparoscopic removal of the inflamed gallbladder. Cholecystitis, or the inflammation of the pancreatic tissue, is called pancreatitis. It is one of the most complex and clinically challenging disorders of the abdomen, and it is classified as acute or chronic according to clinical, morphologic, and histologic criteria. Its causes include excessive and chronic alcohol consumption, obstruction of the hepatopancreatic ampulla by a gallstone or tumor, and even the injection of contrast media during ERCP. Once activated by any of these causes, trypsin, the pancreatic enzyme that is normally excreted through the ducts into the duodenum, begins to auto-digest the organ itself. This has serious consequences, and pancreatitis this has serious consequences and carries high mortality rate. Hemorrhagic pancreatitis is a complication and consists of erosion into the local tissues and blood vessels with subsequent hemorrhaging into the retroperitoneal space. A pseudocyst is a fluid collection caused by pancreatitis, and it is readily visualized by sonographic or CT examination. Symptoms of pancreatitis varies from mild abdominal pain, nausea, and vomiting to severe pain and shock. Radiographic indications of pancreatitis are subtle and previously centered on displacement of the duodenal C loop or stomach by the diseased pancreas or calcified stones within the pancreatic or biliary ducts. So CT has made a major contribution to the diagnosis and staging of acute pancreatitis. ERCP is of value in determining the reasons of acute recurrent pancreatitis. Because pancreatic disease is often asymptomatic in the early stages of disease, sonography is good for assessing the texture and size of the organ. The pancreas is routinely imaged as part of the right upper quadrant sonogram. In most sonographic examinations, the head and body of the pancreas can be measured and compared with normal values for the age of the patient. Pancreatitis is suggested or is sonogrammed by the decreased echo texture and associated enlargement in the size of the organ. Laboratory testing is the most common way to diagnose pancreatitis through evaluation of serum and occasionally the urine amylase level. Management of patients with pancreatitis consists of pain-relieving drug in mild cases and maintaining proper fluid levels to prevent shock. A frequent occurrence in acute pancreatitis, proper dietary restrictions such as abstinence from alcohol are also important. Next inflammatory disease is jaundice. It is a yellowish discoloration of the skin and whites of the eyes. It is not a disease itself, but rather a sign of disease. The accumulation of excess bile pigments, the bilirubin, in the body tissue stains the skin and eyes this yellowish color. Normally, bile and its pigments are secreted into the bowel and eliminated. Bilirubin is a type of bile pigment that is produced when hemoglobin breaks down. Normal serum bilirubin levels are equal to or less than 1 mg per 100 ml but must exceed 3 mg per 100 ml to be visible to the observer. There are two types of jaundice, medical and surgical jaundice. So let us start first with the medical or the non-obstructive jaundice. So this occurs because of hemolytic disease in which too many RBCs are destroyed or because of liver damage from cirrhosis or hepatitis. Its most common appearance is transient in the first few days after birth, when more bile pigments are released that can be handled. A surgical or obstructive jaundice occurs when the biliary system is obstructed and prevents bile from entering the duodenum. A common cause of this obstruction is blockage of the common bile duct caused by stones or masses. The longer the obstruction persists, the more likely it is that complications such as liver injury, infection, or bleeding will arise. The jaundiced patient often undergoes a sonographic examination of the liver, biliary tree, and pancreas to determine if the jaundice is obstructive or non-obstructive. The common bile duct is readily identified. Generally, a normal size implies non-obstructive jaundice, and a dilated common bile duct suggests an obstruction. Now that we're done with the inflammatory disease, let us now proceed with the neoplastic diseases. First is the hepatocellular adenoma. It is a benign tumor of the liver. These occur most often in women using oral contraceptives, which play a role in the development of these benign lesions. So CT and sonography are useful in demonstrating hepatic lesions. So hemangioma is the most common tumor of the liver. It is a benign neoplasm composed of newly formed blood vessels, and these neoplasms may form in other places in the body. Hemangiomas are generally well circumscribed, solitary tumors. They may range in size from microscopic to 20 cm. They are more common in women than in men, especially in postmenopausal women. Normally, the texture of the liver is homogeneous in sonographic evaluation, but an area of increased echogenicity may occasionally be demonstrated. When this appears as a solitary, round lesion, the diagnosis is usually a hemangioma. MRI demonstrates marked hyperintensity on T2 weighted images, which corresponds with fibrosis within the tumor. After an IV injection of a gadolinium contrast agent, peripheral enhancement of the hemangioma occurs in early scans, followed by filling in of the tumor, similar to the appearance on an enhanced CT examination. MRI had a diagnostic advantage when it comes to hemangioma, as it appears to have a higher sensitivity and specificity, especially when MRI contrast is administered, and provides physiologic information regarding the mass. Next is the hepatocellular carcinoma or hepatoma. It is a primary neoplasm of the liver. An association between cirrhosis and hepatocellular carcinoma exists, with chronic hepatitis B or C and alcoholism associated with each. Most primary hepatomas originate in the liver parenchyma, creating a large central mass with smaller satellite nodules. Hepatocellular carcinoma is suspected in patients with cirrhosis who experience an unexpected deterioration, and in patients with increased jaundice, abdominal pain, weight loss, and a right upper quadrant mass. Ascites or a rapid increase in liver size is also one of the suspected in patient. Plain abdominal radiographs may demonstrate hepatomegaly. Sonography and CT are often used to reveal the extent of the tumor. Arteriography may demonstrate the increased vascularity associated with a carcinoma. A definitive diagnosis requires a liver biopsy, generally under sonographic guidance, and surgical resection of the hepatocellular carcinoma represents the only possibility for cure. The general lack of radiosensitivity of these tumors makes radiotherapy ineffective. Metastatic liver lesions are much more common than primary carcinoma because of the liver's role in filtering blood. The liver is a common site for metastases from other primary sites such as the colon, pancreas, stomach, lung, and breast. Primary cancers located in the abdomen, especially those drained by the portal venous system, often metastasize to the liver. Sonography is the most commonly used to screen patients for metastatic liver disease. However, CT and MRI also allow an accurate diagnosis. The recommended treatment for metastatic liver disease is to use a combination of intramuscular injection of a long-acting octreotide, which is a somatostatin analog, and transarterial embolization, especially if the medication fails to decrease the tumor size. So, carcinoma of the gallbladder occurs infrequently, but most neoplasms within the gallbladder are malignant. It is more common in women and older adults. With gallstones present in about 75% of all cases, the symptoms are nonspecific, including right upper quadrant pain, jaundice, and weight loss. Another risk factor associated with the development of gallbladder carcinoma is a porcelain gallbladder, which results from chronic cholecystitis. The best methods for imaging gallbladder carcinoma include CT and sonography. It may appear as a mass replacing the gallbladder or as a polypoid mass within the gallbladder, or the appearance may be as subtle as focal thickening of the gallbladder wall. Pancreatic cancer is usually rapidly fatal and is the fifth most common cause of cancer-related death in the U.S. Its diagnosis is difficult because of the location of the pancreas and the lack of symptoms before extensive local spread. In most cases, the tumor is well advanced before the diagnosis is made. A clear-cut association with cigarette smoking has been demonstrated, and other risk factors include alcoholism, chronic pancreatitis, diabetes mellitus, and a family history of adenocarcinoma. Signs and symptoms are nonspecific and include pain, weight loss, jaundice, fatigue, nausea, vomiting, and diabetes. Carcinomas of the pancreatic head may be visible on barium studies of the stomach and small bowel because the head of the pancreas lies within the duodenal cilium. Carcinomas of the body and tail may affect the duodenal-jejunal junction and cause distortion on the barium-filled small bowel study. Radical surgery as a treatment mode is about the only hope for cure, but it carries a high mortality rate. Radiation therapy is difficult because of the proximity of the pancreas to highly radiosensitive structures such as the spinal cord, and chemotherapy also produces poor results. And that's all for the pathologies of the hepatobiliary system. Thank you so much for listening.